So we are very happy to have you with us. Just some housekeepings. We are welcoming you all to being here. Please make use of the chat box. We are paying attention of the questions you ask, of the comments you make on the chat box. And I just want to quickly go to some housekeeping rules before I introduce Acquire and our experts. My name is Ruth Palnganga. I am a part of the Acquire team. Acquire, you're going to hear about us in a moment. And I am excited to be hosting you for the next couple of minutes, having a conversation with frontline healthcare workers like yourself in different parts of Africa, and listening to them tell us about how change has happened in the institutions. Shall it be the same as our poll? This is a good question to ask. Is it going to be that the government required the change, or was there another impetus, another reason for the change? So this is a good time to reflect together and learn together. So just some quick housekeeping rules. I think I've mentioned before, let's use the chat box. This is a conversation, a discussion more than a presentation. So we hope that you will participate and make this as a learning opportunity for the other people in the room. So make use of the chat box is our request. The second thing we're asking is that you just keep your microphone muted. If you are muted, then we can ensure that we are all hearing one another. Use the chat box. A stable connection will help you. And then we're also asking that you respect the privacy and confidentiality of all participants. So information shared here is considered shared here. So welcome very much. We are grateful to have you be a part of us. Okay, let's go ahead and answer a very simple question. We have these webinars. Acquire hosts these webinars on a monthly basis. Sometimes we're able to get CPD points for more than just doctors, but today we actually only have them for physicians. If you would like to earn CPD points, you're a physician in the room, please put this into the chat box, your full name, your email address, and your registration number. Just those three things are all we need in the chat box, and somebody will email you the code required for you to get the CPD points. So just very straightforward, your full name, your email, your registration number. This month we only have for physicians, but I assure you we are doing everything we can so that we ensure that the March webinar actually has nurses, lab technicians, clinical officers, and as many of the other healthcare worker professionals receiving CPD points by learning and attending these meetings. So let me go ahead and say, so next, we've answered our poll question, so I'm going to go ahead and skip that. Let me spend a few seconds talking about Acquire. What does Acquire do to improve healthcare at the front line? We see ourselves as a bridge to the no-do gap. So our primary role is we are offering learning opportunities to frontline healthcare workers. And the practice that we are pushing is called quality improvement. The science of quality improvement is what you'll hear us talk about. I think you saw in the poll, there was a plan, do, study, act cycle. That is one of the core elements of learning and improving our situations, our learning from the way that we work, and being able to put in measures and practices that allow us to improve in a manner that we're able to measure and learn from what we're measuring. So we really are quite simple. We only have three ways that we're doing this. We work on building the capacity of healthcare workers. We work at creating an enabling environment for evidence-based quality improvement practice within healthcare institutions. And then we are fostering a community that is driving the uptake of quality improvement practice. I think by you participating here, you can say for sure you're part of building the community. We have a WhatsApp group, we send out regular emails, and there's a bunch of activities that are planned for the whole year towards driving this community into our hospitals, into different locations across the continent. So if you're ready, Shiro, I need a yes from you. I'm going to go ahead and introduce our speakers.
Yes.
A few months ago in the month of September, thank you, you're ready. So a few months ago in the month of September, we invited healthcare workers from across the continent to share with us stories of quality improvement. There was a long list of criteria that they needed to meet for it to be considered a quality improvement project. And everyone who met this criteria was awarded a congratulatory amount. But more than anything, we are so happy to have the opportunity to showcase some of these quality improvement changes that you as healthcare professionals are pushing in your situations on the ground. So we're going to hear from Cameroon, from Ethiopia, from Kenya, and from Malawi. And I think at the end of the webinar, we want you to tell us what you thought about the quality improvement changes. You will see they all follow different processes, but they're all arriving at the idea that measurable, quantifiable change is possible when we follow a certain set of methods. We are going to begin with Cameroon. Tumi Divine works at the Bingo Baptist Hospital. It's my pleasure to have met him there. I think about 2 years ago, we got a chance to visit the Bingo Hospital up in the north of Cameroon. They're doing some very good work there, and I'm going to invite Shiro to allow us to hear directly from Tumi himself. Remember, after the 4 presentations, we will get a chance to have the speakers answer any questions or any clarifications on their processes, and we will have a chance to learn together. So allow us to go through all the 4 presentations before we go into the questions. Please, in order not to forget your questions, put it into the chat box and we'll be looking at it. Okay. I am stopping the sharing of results. I am taking everything off. Shiro, over to you. Shiro, you can unmute and tell, okay, good, I can see the screen coming. We have no audio. Okay, do you want us to start with someone else?
There's no audio coming through? Okay, let me try one more time. If not?
Yeah, go ahead. Yeah, go ahead and try one more time, please.
Yeah.
And when you think about patient...
Now the audio is working, so just go back to the beginning. Thank you. No audio anymore. Apologies for the technical challenges. We thought we were avoiding technical challenges by encouraging everyone to record.
There's no audio on your end anymore?
Not at all. No, there's no audio. Yeah.
All right. Maybe we start. We go to the next video, which was for.
Yes, you're welcome. You can go to the next person.
Okay.
Hello all, my name is Asmaka Amano. I'm a medical doctor and quality officer.
The screen is not yet sharing. Okay.
Not to worry. Can you hear this video?
Hello,
yes, go ahead.
My name is Asmaka Amano. I'm a medical doctor and quality officer in the multi-parent poster. This is a project we have done 2 years ago when I was the head of the patient department in a hospital, and this is stuff that involved in this project. Back then, we were looking for problems that we can solve with our project ideas. This is early 2022. And we have identified around 5 or 4 problems, including poor gross body monitoring for under 5 children, low pain scoring metrics are recurring, and as well as low patient satisfaction. We have evaluated and we scored and ranked these 4 or 5 problems, and low patient satisfaction, which I believe at the time was 70%, became high in the prioritization matrix, and we want to focus on that problem. And so once we focus this one problem, we ask ourselves, this is not really the main problem, it's just a symptom of the problem. So what is really deep down in this problem that is causing the root cause of the problem? So we have used different root cause analysis techniques and tools, including the 5 why question, which was important for us to find out the root cause of the problem. And we ask ourselves, why are patients dissatisfied with our services? And we come to understand that there was a communication gap between why they are admitted and why they're taking the treatment, and how long would be the course of the 3 months. So this left the patient with no lack of information and distress and dissatisfaction with the service. So why there is a communication gap in the first place? They are in hospital, we are around. So why this communication gap existed? And we come to understand that there was less contact between the patient and the staff, especially the workforces. That was due to mostly irregular nursing grounds. Of course, we have ground nursing ground, but ground nursing ground is not a perfect place to start contact and close information sharing with the patient. So there was this problem where there was irregular nursing grounds, and we asked why there is irregular nursing grounds, and we found out that the absence of scheduling and planning of nursing grounds was the main issue that was causing irregular nursing grounds, which I believe at the time was less than 2 days a week and once a day. So we aim to increase this number from less than 2 days a week to 5 days a week and 3 times a day in every shift. So nurse have 3 shifts at the time. So we want to make nursing ground happen in every shift, which was bold and ambitious at the time, and actually united and galvanized the staff to actually achieve this bold but very important problems that we need to solve. And so once we understood our problem, the next question was, so what we're going to do about this? And at the beginning, we set out to find a solution. So we have to actually find a solution, and we will start brainstorming and how we can do and what's actually possible. And a lot of ideas was thrown. I think 4, 5, 10 solution ideas was thrown, and change ideas came, and we used a focusing matrix based on importance, how important the solution of the change idea was, and how feasible it is to carry out the change ideas or implement it with our own capacity. And with those filtering that we have used, we have actually come to 2 important change ideas. One is a logbook scheduling and documentation of nursing grounds, which makes, and also regular monitoring and evaluation, which make the process instill and also adoption of the new change ideas. So we have focused on these 2 solutions in specific problems that we hope to achieve. So with this we jump to implementation. We have planned to achieve this goal within 3 months, that is 12 weeks. And we can see from this chart, we have accounts on y-axis, and we have the weeks, 12 weeks on x-axis. So the first 3 weeks, I think there was a lot of excitement. A lot of people want to achieve this aspirational goal of getting out nursing ground not only 5 days a week, but like 3 times a day in every shift. So there was an increment. That was very promising increments after the 3 weeks. And I believe from 40-something%, we have jumped to 80%. But in the 4th week, there was a problem. So we see that there is a rolling back of the progress, and sometimes even the nursing ground not happening, and most of the activities in nursing ground were jumped. We have actually have 6 or 4 metrics, important activities need to be done in nursing grounds. Those are not being done. And we found out that because the problem was there was a lot of documentation. This logbook have a lot of documentation, and most of them they have to do repetitive job for every patient. So the writing was a problem, especially keeping the record. And due to this, the staff were actually jumping up some of the activities they were doing. So what we have done is actually we coded the change ideas in the documentation. So they don't have to really write the same information all every other time they new patients. So rather they use these codes and make the process very easy and simple. And with that, we have seen a real shift. And in next 2-3 weeks, we have seen as progressive and a steady increase in the performance. So at the end of this project, what was the lesson learned? What actually we learned in doing this project as a team, as a department, and as a person for myself? And the first thing was staff buy-ins and mobilization is an important part of having a successful project. You cannot really do this without inspiring your team and also mobilizing and galvanizing them in this one specific thing that you're doing towards you can achieve something, which makes it effective and successful. The other thing is leadership support. When you're doing projects, a lot of things might not go the way you think, and sometimes you face this problem where you cannot fix by your own or your department, so you have to actually have support from your leadership that can facilitate the change ideas, maybe something you want to implement, you cannot implement. So this time, having a leadership support is as essential as every other part in project implementation. The other was early consideration of a sustainability plan. Remember, you're running a project not just to do it for 3, 4, 5 months, but you rather want to find out what idea really works and you want to adopt that one. So like the PDCA cycle exactly like that. Either you adopt it or you adapt it, or actually you just avoid it. So you don't have to do either. So I think having sustainability plan early, not necessarily at the end of the project, but from early is a good idea. So you can actually adopt those best ideas and best practices, and you can make them part of your daily practice. So thank you for listening. This was the experience we have done running a strengthening nursing ground projects. And by the way, at the end, the patient satisfaction grew above 19%. And nursing ground was actually more than 90% as well. So we were extremely successful in achieving both of our goals that we hope to achieve when we start this project. Thank you for listening.
Thank you very much, Asnake, and congratulations. That's a fantastic example of a project. I think your resourcefulness should be applauded, bringing the team together, getting them through identifying a problem and actually working towards a solution. We don't take that for granted. I want to invite Asnake to say hello to us as I ask him a question. I don't know if you've been able to log on. If you can just unmute and say good afternoon to us as I ask you an important question.
Let's go forward with our next speaker. Asnake has had trouble logging on. I have not been able to find him.
Not a problem. I think we can go ahead with that. Tumi Divine. Let's go ahead and see if tell me if the audio is working.
Good afternoon.
Is
That's
the audio working?
Audio
Okay.
working.
Great. Let's go ahead.
Thank you all for having me, and good afternoon. I will not belabor you with the introduction again, but I will tell you about my time with Acquire and IHI. That was 3 years, and what I did in our hospital, Bingo Baptist Hospital. So we all know that quality health care, immediately, when you think about quality health care, you immediately think about patient safety. And when you think about patient safety, the next thing you think about is you should think about staff satisfaction, which is very, very important, and is linked to patient safety with other factors that we will not mention here, since we will only focus on staff satisfaction. It is in this light that I was contacted and I joined Acquire and IHI, and we immediately, myself, Mr. Lucon Franklin, Florence, and Pascal, decided to assess the Joy at Work and to see how it could be improved in Bingo Baptist Hospital. Bingo Baptist Hospital is a tertiary hospital in the northwest region of Cameroon, sub-Saharan Africa, and it has a staff of about 800, both medical and non-medical. So it is true that Joy at Work is hard to come by in our hospital. Staff turnover is also not helping. Pre-pandemic and the ongoing war that is in our region right now, we used to see around 600 to 1,000 patients per day from over several countries. So the purpose for our study was to work on improving Joy at Work in our institutions and subsequently maintain or even improve on the quality care in our hospital. We know quality care is directly related to staff satisfaction. This will largely be by listening qualitatively to the patient, to the people, and working on a way that should help in this light. It has been noticed that the standard of care in our hospital is not what it used to be. In a qualitative continuous assessment, we had boxes and papers of 2 colors placed in the intensive care unit, and means what? These colored papers are to be taken and put in the boxes at the end of the day, depending on how the day was, red or yellow in a qualitative assessment. Red stood for a bad day and yellow stood for a good day. In a roundtable setting, we asked these questions: what matters to you at work? We had a discussion with the nurses in 2 words, asking them what matters to you at work. And they wrote on sticky papers, and we placed them on cardboard. These cardboards were meant for everyone to see, the administration, the leaders, everyone was meant to pass around and see this board. But we did not, they did not write their names on these sticky papers, so their concerns could be reached without any punitive or any being afraid of any feedback from this. So this is an example of how we had the papers placed at different points. We then group what they brought forward into, is it a communication problem? This was very important. Is it an equipment problem? Is it patient satisfaction problem? We also, some people talked about patient satisfaction. Is it a failure to upgrade? They mentioned we group them because they will not directly talk probably on what is here. So we group them. Things that were related to salary, was it delayed? Was it not coming at all? What they wrote, and we grouped them together. Doctors not paying attention to nurses, recommendations, no appreciation from the authority, memories of dead patients. We had several things that we tried to group and see how to express it to them. This is an example of that grouping. If you look here, you'll see communications. We had 3 that we have presented in the ICU. For communications in the men's ward, we had 8 that wrote things related to communications, probably in the ward with other nurses or with the patients or issues like this. And then we made it. I made it in this diagram to see the very many and the very few, but important. You see equipment here in ICU was something to talk about that was important. affecting their work and then was contributing to their satisfaction or joy at work at the end of the day. So if you look at the men's ward, like we mentioned, communication was a serious problem. What did we do as an intervention now to come back and then review if there is a change? This was how initially we assessed them and we looked at what was happening at the beginning. If you look at it here, you notice the good days were quite lower compared to the bad days here in this diagram, and the same for men's ward. You only see the bad days are up, and this explains the environment into which we find ourselves here. Probably most because COVID is gone, but then still the war is ongoing, and there is that fear. For example, the tasks that we assigned, either Franklin or Florence or Pascal or myself, I took the assignment of seeing doctors and talking with them, directly mentioning to them about the nurses complaining that they don't listen to them and that they don't pay attention to what they found, given that most of the time they stay with the patients more than the doctors. I was also, one of us, Florence, was assigned to talk about ways of good communication. She had actually had a presentation where they followed up and to see what is happening. In addition, I was also directed to talk in a serious manner, not like since he's one of us, we could just allow it as such. I spoke with him and shared with him one of the reasons that was making people not to be happy at work. Though we visited 2 wards, we assume that this cuts across all of them. And it is important to note that as we intervened, we were still looking at them choosing the colors, the red ones and the yellow ones. When we talk to the nurses, it will sound like there is an important change. But then when we look at our graph here for the bad and good days, we still found out that the bad days were still more than the good days. This was probably from a confounding effect, our environment didn't change at all, with the war still persisting and the rest. And for that reason, salaries didn't come on time because of low turnout. And yeah, this is how it happened. Thank you.
So thank you very much, Tumi. I want to invite you to come in and say hello and then tell us which one of these changes is going on to date. Which one, if we walked into Bingo Baptist Hospital today, would any of these changes be considered they are continuing being implemented? Or was it a one-off that ended with the project? Please, I want to welcome you to say hello and let us know if the change is going on. Tumi Divine, I can see that you are here. I've asked you to unmute.
Okay, thank you. I couldn't unmute myself. I was trying and it was difficult. As of now, we some of the issues, just like I mentioned at the end, are still persisting. And just like I mentioned also, if we look, we'll see that when we talk with the nurses, they will tell us that because of our interventions, they have had a change. They have had the colleague-to-colleague communication. The equipment is better. But I believe that if we still put back the boxes, probably the bad days will still be more than the good days, you know. But that is a dilemma that we find ourselves inside right now. So where we choose to make a change, probably was so close to the staff, and probably that is why we were unable to make a significant change in their days, or to make them improve on joy at work, and just like I mentioned, eventually improving on the on quality care in our hospital. Thank you.
Thank you very much. To me, I just want to congratulate you. It is not, improvements take time, and we note the progress. It will take year after year, several months and years of continued work to see the progress. But I think the ambition of giving all of us the opportunity to have joy at work by making useful improvement changes, listening and finding out what their problems are, and then addressing them, I think that is worth applause, and we congratulate you. Shiro, are you in the room, and are you able to share with us the next presentation?
Yes, I can.
Please go ahead.
Is it audible?
Yes.
Susan Karusa Kisanya from Kenya.
The sound went off. Is anyone else hearing it?
Is this for everybody?
County. The background objective of this research was to strengthen behavior change on maternal infants and young child feeding practices in Musanda. Overall aim of the study was to identify children before the age of 5 years who were malnourished, and possible intervention put in place using locally available foods. Verbal autopsy done in 2023 showed that 44% of under 5 mortality was caused by malnutrition, 33.3% being severe cases in Musanda. Screening of children conducted in outreaches by weight and mark taking at household levels led to identifying 307 children with faltering growth in Musanda, which represents 44.4% of Mumia.
So the screen has stopped playing, Shiro. I don't know what is going on.
I see lips moving, but not the voice. I'm getting chat box that others can't hear, so we will readjust and start the video again.
The background and objective of this research was to strengthen behavior change on maternal infants and young child feeding practices in Musanda. Overall aim of the study was to identify children before the age of 5 years who were malnourished, and possible intervention put in place using locally available foods. Verbal autopsy done in 2023 showed that 44% of under 5 mortality was caused by malnutrition, 33% 33.3% being severe cases in Musanda. Screening of children conducted in outreaches by weight and mark taking at household levels led to identifying 307 children with faltering growth in Musanda, which represents 44.4% of Mumias West Sub-County, according to the Kenya Health Information System 2023. Health education on good nutrition and 10 food groups to expectant mothers and children aged 6 months and above was key, since Kakamega County stunting growth stands at 11.5, under 5 representing 28,652 children. Underweight is at 6.4, that is 15,945. Estimated cases of low birth weight at 3,737. The importance of the exclusive breastfeeding for children of 0 to 6 months was highly encouraged. So according to the KHIS data results from Sanda Dispensary 2022, October, you can see the difference. In 2022, we had few cases. For example, faltering growth was at 5. We got 5 children, but in 2023, the number had increased tremendously. That is to 307. So each indicator, like MWAC yellow, MWAC red, you can see in MWAC yellow in 2022 was 8, but in 2023 was 70. The children we got were 74. Those whose mark was red was 0 in 2022, and in 2023 we had 20 children. Therefore, what does that mean? This means that in 2022, few cases were identified compared to 2023, whereby the indicators increased. This is because in 2023 we conducted outreaches. And also we did household to household visitation, screening all children below the age of 5 years. The results of the study was total number of screened were 506. That is children below the age of 5 years. Children with moderate malnutrition, whose mark was yellow, was 122. That is 24.1%. Children with severe malnutrition, whose mark was red, was 25. That is representing 4.9%. Total underweight was 160. That is representing 33.3%. Between April to October 2023, a total of 105 children, representing 86% with moderate malnutrition, and 20 severe cases out of 25, that is representing 80%. And finally, a total underweight of 112 out of 160, representing 66.2% had improved, as shown in the graph below. So you can look at that graph. That is before the screening and after screening and the interventions that took place. You can see that the figures, that is the moderate malnutrition, severe malnutrition, children whose weight was underweight, you'll find that that reduced greatly. Now, in 2022 to March 2023, child mortality was recorded to be 29. That is as from 2022 to March 2023. We lost 29 children, but after the intervention, there's been no child mortality since April 2023 to date February 2024. 7 children diagnosed with delayed developmental milestones were referred to Education and Assessment Resource Center, EAC, and have greatly improved. Another result and another achievement, you find that morbidity in children has greatly reduced since the growth and monitoring is observed. Defaulter tracing of children in immunization were identified and given services. Also, the caretakers were given services like family planning, cancer screening, HIV testing and counseling, health education on nutrition water and hygiene, that is WASH, among others. So I would wish to recommend the following. One, the CHPs or community health promoters play a very key role in this eradication of malnutrition. Therefore, they should be trained on the health promoters on how to use the community health promoters kits, because that kit has tools like MWAC tapes, it has weighing scales, it has glucometer, it has blood pressure machine. So if they can be trained on how to use them, they'll screen these children at household level, and we find out that they can help even apart from even malnutrition, other diseases like diabetes and hypertension can also be identified, and early diagnosis or early screening will help in treatment of such diseases. To embrace baby-friendly community initiative, where mother-to-mother support groups are formed at community level. They meet together, they discuss health issues together with healthcare workers. The practices of positive deviance health, this is where mothers meet in community prepare and feed their children using locally available foods. Outreach and household visits to be conducted regularly on follow-up of growth and monitoring of children. Involvement of healthcare workers from the link facility, Ministry of Health, stakeholders, e.g. Ministry of Agriculture, because at the end of the day, we need food, and therefore this Ministry of Agriculture plays a very key role. Social services, children's department, and male involvement in eradicating malnutrition. I would like also to advise the African countries that have high malnutrition rate can adopt this method, technology, and knowledge to eradicate malnutrition. For instance, we have countries that are also suffering from malnutrition. We can adopt this and eradicate malnutrition. I would like to acknowledge, I would like to appreciate Acquire for giving me such an opportunity. USAID Boresha Jamii and Ministry of Health. The first slide that I sent, there were 20. We have pictures. The pictorials also say indicating.
So thank you very much, Susan. I want to invite you to tell us if we came today, would we find the same results? I think that's the question we are asking. Susan, would you go ahead? Hi, Susan. If we came today, would we find the same results? You're very welcome. Congratulations on the changes. If we came and we checked the under 5 children today, would we come and find the same results? Come on, tell us if the changes and the improvements are continuing.
Yes, they are. They are, and if you come even right now, you'll find this what I've presented, because this report I presented up to is February 2024.
Thank you very much. Then let me offer you the congratulations that are due to you. If there are any questions for Susan, please put them into the chat, and in the last few minutes, we will have a chance to say hello to her. Let me quickly move, because we're running out of time, to Maria Enzo. It's still loading on my screen, but hopefully it shall be ready just in a few seconds.
My name is Maria Enzo Banda, Enisic Officer at Malawi Health Center. I'll take you through the presentation. Just to give you a quick overview of Madara Baneta Center. It is located in the city of Zomba. It has a catchment population of 58,999 with an average of 107 maternal admissions per month. There are a total of 132 staff members, of which 29 are nurses. And out of that 29, 26 are midwives. And there are only 10 health care workers which are trained in quality improvement. At maternity department, 5 nurses are assigned during the day and 2 nurses are assigned during the night. Madara Urban Health Center is located 8.1 kilometers away from Zomba Central Hospital as our little site. Every month, we do conduct our data review meetings. So during data review, that is in the month of September 2022, we noted that we had 3 problems. And out of that 3 problems, one of the problems was reduced number of maternal health center manageable referrals. So we regarded it as our project just because it scored the highest after prioritization matrix. Our problem statement is that this problem has been a problem since September 2022, and it was discovered through monthly report and data analysis, and it occurs every month. And our baseline data was 64%. This leads to overcrowding to little site. As a result, leads to workload, hence it leads to increased number of maternal death and NNDs. And even it's expensive to our clients. So how we came up with our baseline data, we had 6 data points from March to August. We had to rearrange them from the lowest to the highest and come up with the median. So our median was 64.5, which is 64%, meaning this 64%, we are supposed to be helped at Malawi Center, but we referred them to Zomba Syndrome, making them unnecessary fellows. So our aim was to reduce number of maternal health center manageable fellows from 64% to 31%, from the month of 20th October 2022 to 31 December 2022. After coming up with the M statement, we had to sit down and brainstorm the causes of unnecessary fellows. So it happened that all the causes which were mentioned were falling to one side, which is the health care worker. So just because it was one side, the health care worker, we decided to use the 5 whys to come up with the root cause. So our root cause was lack of knowledge and skills. After coming up with the root cause analysis, we came up with the PDSS cycle because we had 3 change ideas. So all those 3 change ideas had its own PDSS cycle. I won't talk much about the PDSS cycle just because of time, but with me here, I've got 3 learning charts, of which 2 learning charts, of which I'll talk much on the second learning chart, just because this first learning chart is just telling us how we tested our change ideas, just because before implementing a change idea, we have to test it on a small scale, and our change ideas were tested for a week. So, as I've said, I'll explain much on my second learning chart. So the second learning chart, the first change idea was peer-to-peer mentorship and supervision. This change idea was tested in September, and the outcome dropped to 46%. Remember, our target is 31%, but we dropped to 46%. Therefore, we decided to adopt the change idea and come up with another second change idea, which is CPD sessions of global assessment. So during this CPD sessions, we also addressed the gaps which were discovered during peer-to-peer mentorship and supervision. After testing this change idea, we noted that we dropped to our desired outcome, which is 31%. Therefore, we adapted the change idea, but we also thought it was that we can even do much better. So we added another third change idea, which is assessment before referral by a second on call. At Malawi Urban Health Center, if you have decided to refer a patient, there was no need of consulting. So just because of that, we wanted to be having a second opinion, whereby another second on call to come assess the patient, then make a decision and refer necessary. So after adding this change idea, did great, and it was a successful one. We came up to 23%. So as you can see, our target was 31, but we managed to get 23%. So as you can see, this project, it was done a long time ago, but we are still monitoring it, and we have implemented, we have adapted all the change ideas. So this is a successful story. And during the project, we have the best practices and the successes. We managed to reduce the number of long referrals successfully, comprehensive handovers using our handover policy, which was developed during the project. Daily case audits are done by blankists and WITs that meet consistently, adding a Zomba Central member into our WIT for easy access to data concerning our referred cases, involving a second on call for assessment and decision making. Thank you.
Thank you very much, Marienzo. I want to go ahead and invite you to close for us as you tell us whether any of these changes we would find if we came onto the ground in Malawi. Would we find any of these changes are they ongoing in the Matawala Urban Health Center?
Yes, you're going to find them all, just because that's still project. And all the change ideas which I've said here have been adapted. So you're going to find them.
Thank you, everybody. Usually we try to end and start on time. So allow me to close by thanking our speakers. We are thankful for the examples shared from Malawi, from Ethiopia, from Kenya, and from Cameroon. We are going to go ahead. We will share the videos with you. We will go ahead and share the videos. Go ahead and share the slides as well. We apologize for some of the technical difficulties that have taken place today. I think we are learning a lot of lessons about how to make use of the situation when we are in different locations. We will be prompting you by email to share with us if there are any lessons learned, or alternatively, if there are opportunities to share the quality improvement lessons from your institution. Thank you, everybody. Please go ahead and you can tell us if there's anything that stood out to you in the presentations. As we say goodbye to one another, we are grateful for your time. We are grateful for each of the lessons that you have chosen to share with us. Have a good evening. Have a good afternoon, everybody.